Good afternoon, everybody. My name's Paul Barrett. I'm from a company called CGI, and we're going to talk today briefly for about 20 minutes about the role that e-prescribing plays in patient safety. I'm Business Development Director for CGI in Healthcare. To my right, we have our friends and colleagues from Taunton and Somerset NHS Foundation Trust, David Chalkley and Mark Dyer, and our partners from a company called Morand and Jay, and we'll take you through a brief presentation. CGI in the UK have been around for about 25 years. We've 5,000 clients, 6,000 people based in the UK, but we're a little bit of a hidden gem in that we do what we do in government and in healthcare and do it well, but don't necessarily publicise it widely. A lot of that is due to some of the contracts that we're involved in being incredibly secret for some of the organisations that we work for. But you can see there we have a number of offices across the UK, and we're a significant organisation. In terms of our role in e-prescribing and meds, what we have is a tripartite agreement and arrangement with our partners Morand, who developed the software. I won't steal thunder, they'll tell you about it a little bit later. We work very closely with the Ipsc Foundation, which is part of NHS England and NHS Digital, and they're the custodians of the UK version of the code and the solution that we're going to talk about in e-prescribing. And then you have CGI as the systems integrator, implementation partner of Morand, so we deliver the solution and implement it as we speak, quite literally. We don't just do EPMA in the UK. We have a number of clients who are listed, as you can see, Isle of Wight, Solent, and a number of others. We are NP fit independent, so we have no legacy product that we are trying to shoehorn into the UK market. We go where the trends take us, and our core propositions in that respect sit around e-prescribing, an integrated digital care record, which joins up local health care economies across, irrespective of discipline and irrespective of delivery organisation, if that indeed is a local authority. And we're a strategic ICT partner for a number of trusts, but here today to talk about e-prescribing, as I say. Our friends on my right from Taunton and Somerset will start. We are delivering EPMA into 2 trusts currently, expected to go live early this year. One is Plymouth, and the second is Taunton and Somerset NHS Foundation Trust.
Thank you. I think our presentation will be quite short today, so hopefully we'll catch up. I'm a consultant cardiologist at Taunton. I probably should have started putting up an X-ray of one of my NEBA events. And I should probably confess that we're rated good by the CQC, although there was room for improvement with clinical safety. And I'm hoping that our journey along the sort of EPMA pathway will mean that the next time we're assessed, we'll score slightly more highly. We are totally unlike the major London trusts where I used to work before I moved there. We're a much more small and friendly organisation, but we cover quite a wide geographical area. Patients can spend several hours getting to us, and not because of traffic. We are constantly full, constantly busy, and constantly focused on numbers. The first thing I'm going to do is hand over to David and tell you, who's going to tell you a little bit more about the journey so far.
Thank you, Mark. So, yeah, just a little bit more background. We started our EPMA journey probably about 18 months ago, when we started a selection and procurement process, which was fairly lengthy, but we learned a lot along the way. And now we're kind of 6 months into the project to get EPMA implemented with the view to trying to be live in the summer with the system. And really, it starts with, well, why electronic prescribing and medicines administration? Well, for us, EPMA is about safer patient care. It's also about making the lives of those that deliver that care and those that receive the care, making them better, so trying to make things easier. Our journey really was started with data, and we're trying to underpin what we do with data. So as you can see, we have a range of metrics and data that we've collected along the years, around incomplete prescriptions, ambiguous prescriptions, allergy interventions by pharmacists, clinical interventions. And these stay reasonably steady, but it's things that are intervened on a daily basis. We also have frequent incident reports, and we recognise what comes through as medicines incident reports is probably, to a large extent, just the tip of the iceberg. These are the ones that people take the time to report, and these are also the ones that people detect. Behind that, on the national scale out there, there is a body of evidence around the medication errors and the level of harm that those can lead to. And the data that we've gathered has shown that there's quite a burden on the staff within the organisation around things like medicines administration chart rewrites. We're looking at around about 4,000 of those a year. Transcribed medicines onto discharge summaries, 160,000 a year, and they're just the ones that people actually take the time to transcribe onto the discharge summaries. There's a whole host more that should be on discharge summaries that probably get missed off. So as a digital exemplar, we really have a duty to look at these problems and try and bring about the digital transformation that can support the organisation in improving processes and ultimately delivering better outcomes. So system selection for us, it was really centred initially, or the whole journey, has been centred around users, patients, and the organisation as a whole, and really trying to work out what problems we want to solve, and what is the best solution and partnership that we can form to solve these challenges. So usability and workflow, when we looked at the systems, it was really critical to us that we tried to look for a system or a solution that would give a degree of workflow reliability, and that really was assessed using clinicians across the board of all specialties and types to help us identify which they felt was the most usable solution, with our view being that is critical to workflow reliability, and workflow reliability will bring about safety. It's all underpinned by benefits, so what we wanted was, where we saw the systems in action, we wanted people to be able to demonstrate and show us the data that underpinned the safe use of their system. Standards and integration is quite a technical thing, but again, it's been really important for us that we put in a system that can talk to other systems, that can bring data together, and that can present it in views and in ways that really benefit clinicians. So although we're putting in a best of breed solution, actually you'll seamlessly transition between the systems that clinicians use in their everyday life and e-prescribing. Opportunity and partnership and values, we wanted to make sure that we identified a partner and a system that could bring us more than just a standard EPMA delivery, that actually could track into other benefits across the organisation, and I'll come on to those in a minute. And then strategic alignment, being a GDE site, having ambitions as a trust, we need to make sure what we selected ultimately fitted in with the overall vision for our organisation. Now, project delivery, central with everything that we do is team, and we spent a lot of time as an organisation and as a digital programme really investing in internal capacity and capability, and trying to bring clinical staff into the digital realm and really build a team of kind of clinical informaticians, making sure that we represent doctors, nurses, allied healthcare professionals, and that's what we have at the core of what we do. The other thing, and kind of demonstrated in the image to your right, is we've spent a lot of time focusing on personal engagement, particularly with the patient. So we have steering groups with patient representation. We've run workshops whereby we invite patients to come and explain their problems and their views, so that we can factor this into the way we engage as a project, and also the way that we solve problems. We have a duty, not only as a GD, but as an NHS trust, to really try and share the experiences that we have, whether it be good, whether it be not so good. We've developed an EPMA blueprint, which is being made available for other sites to look at and to learn from, and we're really keen to partner with other organisations and learn from them, and try and embed kind of an adapt and adopt culture, rather than try and build kind of invent our own wheels. Then data and clinical safety, a lot of that goes quite hand in hand. We've spent quite a bit of time investing in the right clinical safety structure within the organisation, particularly on the digital front, and that involves getting clinicians, technical teams to really sit down and scrutinise the systems that we're developing, that we're implementing before we put them in. And like I say, it's all underpinned by data, and very much, that's a core thing for us, that we can demonstrate we've improved the system, and also, if there is harm that is being caused by the solution, that we can identify that and hopefully resolve it. So just coming on to opportunities, the system that we've selected and the way we've approached is we wanted something that runs across platforms, that is flexible, that is highly usable, and that can be accessed in a range of ways that mean that clinicians don't always have to go to the same places to find that information, and that it can be hopefully in their fingertips or just an arm's reach away. In terms of interoperability, we're working closely with NHS England and NHS Digital to support first-of-type implementations of fire standards and things that really will drive forward the integration agenda. So we're looking to integrate the Mirand Open EP solution with the JSE pharmacy stock control system, which would be quite a value-bringing achievement for us as an organisation, but actually for the NHS as a whole, showing that we can develop a new type of interoperability would bring a lot of benefits. Our other partners that are implementing EPMA, that the picture again on the right is our team down in Plymouth, supporting them with their user acceptance testing. We've spent a lot of time collaborating with other sites, and we plan to support other people on their journeys by going down and offering hands-on support wherever we can free up capacity. And like I say, we see this as just an integral part of delivering these type of solutions. The next thing as a key opportunity as well lies really within the data. The system we've selected is built on open standards. It's designed to facilitate interoperability, and it gives us our data in a vendor-neutral format. Now, for us, that's really important. One, we can start to integrate in different forms of data within the context of prescribing and administration. So we can present laboratory results, so whether that be INR, whether it be blood glucose, whether it be renal function, we can start to present those within the context of prescribing and administration to make sure people have the right information at the right time to make the right decisions. And also having the data stored and accessible in the way that we will have it, it will also facilitate what we hope will be a greater level of research on the data, analytics, as we look to deliver a second layer of improvements beyond improvements just in the administration and prescribing of medicines. And so we'll be putting it coupled alongside the EPMAs, the ThinkAir platform. Now, this is an open air platform that we have the potential to build more than just the EPMA system on top of, but kind of best of all, it will enable us to connect the data and use it in a way that we don't have with a lot of other systems. So I'm just going to hand back to Mark, because I think our journey so far, one of the key learnings is really taking those that are most affected by the change along with us, and really trying to learn from their problems, from their experiences, and critical is going to be is going to be the adoption of those users to this new system, and how well they really engage with the solution and drive out those successes.
From my perspective as a clinician, I wasn't so concerned about interoperability and data and other bits and pieces. I just wanted to get rid of this. I was asked, we got sent a deadline saying you've got to produce your slides by X date, and I can't remember the date, but I went to the ward and saw one of my patients. I thought this would be a good one. And this is just a typical drug chart, as you can see, with all the crossings out and the initials and things not clear. And I don't know how many of you, but I think quite a lot of you in this room will undertake investigations. And for those of you who work in environments where you're still using paper drug charts, trying to work out what's being given when and by whom is an almost impossible task. And yet I have to go there and see this patient and take responsibility. And when things go wrong, I have to stand there in front of the relatives, and they will say, well, they weren't given their medication. And you'll sit there and look at the drug chart and try and answer these questions. And you just say, well, that may be the case. I just don't know. And the more you look at this drug chart, and I won't go through it in detail, the worse it gets. But this is just one drug chart. And of course, most of our patients now are elderly, and they have many drug charts. And it's not very clear when they have many drug charts. And you can find patients who haven't been given drugs on their second drug chart for days on end because nobody's noticed. And then, of course, it's a bit of paper along with 3,000 other bits of paper on a ward, and you can't find it. But one of the interesting things that's come up is that although we can see a lot of upsides to going to electronic prescribing, some of those upsides are also potential negatives. So you might think that having a chart available is a good thing, and it is, and there's nothing more frustrating than not being able to find a drug chart when you're trying to work out what's going on with the patient. But equally, if you can just see the drug chart from your office, the more you can see from your office, the more coffee you can drink. And there's something about going to see a patient, because seeing a patient tells you a lot more than a drug chart or an e-Obs platform or a digital note or something else. So we've got to be careful when we implement it that we don't lose some of the reviews. And the pharmacists were saying, great, we can do all our medicines reconciliation from our office. And that would be a disaster, because I can't then find a friendly pharmacist on the ward to tell me about whether I can give this in someone with renal dysfunction or whether these two drugs go together or not. And we can put in, and we are going to put in software to prevent inappropriate prescribing. And, you know, I operate on patients, and I've had patients have terrible hematomas where people have been given Clexane and other low molecular weight heparins, and then someone started a DOAC, Apixaban or Rivaroxaban, and the two have continued because nobody's thought to cross one off. And getting the right software and the right rules in place is going to prevent those problems. But equally, if you don't get the rules right, then you can hobble the software and make it unusable and frustrate users, and they will just click through warnings and ignore them because they'll get alert fatigue. So we've still got a lot of work to do to get that right and to set that up. And the pharmacists are quite excited. They're quite exciting as well. Not David. Sorry. But they'll be able to control what we're prescribing. And that's quite a good thing. And I'll finally might issue a prescription for diltiazem that they like. But the other thing is you're going to be there on call, and someone's going to come from France or another country, and they're going to be taking a drug that the pharmacy doesn't stock. And so we've got to work out ways whereby you've still got that flexibility. There's no doubt that not having handwriting to interpret is going to be a good thing. And there's no doubt it's going to be much easier to know what's been dispensed, when it's been dispensed, and by whom. And it's going to be much easier to understand why drugs haven't been given, which is still often when you go onto the ward and you sit there and you say, well, why haven't they been getting this drug? Everybody looks at their feet, and you sort of have to go, I see, it's someone else who's done that. The one thing the juniors are concerned about, however, is time. Many of ours have worked in places other than the Southwest where they do have e-prescribing already, and they've said it takes more time. And when we are inundated, and we're in the midst of winter at the moment, we're on Opal 3, whatever that means, and I think we were on Opal 4 yesterday, people haven't got time anymore, and spending longer and longer putting drugs into a chart is something that frustrates people when you've got 25 or 30 patients waiting to be assessed. And delaying the assessment of patients presents a safety risk in itself. And then there's some upfront costs, because sadly it's not free. CGI are a very efficient and well-known and successful organisation for a reason, as are Moran's. And you've also got to spend time training people, and that takes them away from the front line, and that costs the institution. It doesn't cost them anything to issue more drug charts other than the cost of the paper, which is relatively cheap. And the other thing we think about is it's very hard for me to write amoxicillin and not, intend to write amoxicillin and write the wrong drug. Whereas if we're not careful, people can click on the wrong drug and select the wrong drug by accident. So we're going to have to monitor a lot of things to make sure what we're doing is safe.
Since we're more or less over the time, I'll just compact my slides into a couple of key messages. So the product itself, OpenEP, covers all the aspects of inpatient prescribing. And we worked really hard with several hospitals in Slovenia as well as with NHS to localize it and make it very user-friendly. Because, and this is what I'd like to show you today, we really understood when we started working with the Children's Hospital, where the whole development of OpenEP started, that when you're introducing healthcare IT in a very complex environment such as hospitals, either ICU or other wards, you need to be really, really careful that by introducing software, you don't overcomplicate things as they already are. So it shouldn't happen what you see here on the picture, that software is actually taking away the medical team's focus from the patient to the screens. But the software that is used needs to be done in a way that medical teams can actually work together with the patients, and the software needs to help them with the day-to-day work. We need to understand that medical teams are not there to be good at the products and software we develop, but they need to be good at the work they're doing. And as someone who's delivering the software, this was very crucial for us to understand, because this gave us guidance on a day-to-day basis. When we are designing these systems, we are always placing ourselves in the shoes of our users. And at the end of the day, what happens is that there's, IT can really help in a way that can reduce cognitive load of all the medical teams by having the data readily available in a format which they can then use to make better decisions about the treatments of the patients. And in order to do that, of course, the data needs to be available. And ePMA is actually a really good example about that, because when you're doing prescribing, it's not just medications. You also need observations, you need body weight, you need body height. In certain examples, you would also need labs to help with certain decisions. You need allergy data, you also need conditions data. And all of this is possible with IT if done properly, so that it's presented in a way that medical teams can understand it, be warned about specific use cases, but then at the same time, it needs to be designed in a way that it also allows some edge use cases to happen as well, and not prevent the flow of the patient care. And well, that's it. The colleagues put it really nicely, so thank you very much.